All right, so today I'm going to talk a little bit about a topic that's near and dear, and because I've been around long enough, I'm going to give you history, sadly. So I also have a couple of slides in here that I'm going to ask you questions to answer. So I'm going to look and see. I see some of the residents in here, so I'll probably pick on you guys. All right. So my disclosure is that I do data safety review for the Intrepid Trial, which will be published hopefully in the next year or so. That is with Bard Medical looking at normothermia, but I am totally neutral, like Switzerland. Okay, so what we're going to talk about for the next 50 minutes or so is going to be a little bit of history and physiology, a little epidemiology about temperature management specific to acute brain injury, a little bit of the science and the background, the reality of what we've learned in the last 20 to 30 years, in this, and then sort of the practical suggested approach for our patients, and how we can synthesize all of the information we have. And I know that there are many very distinguished scientists listening to this who will have strong opinions probably, and potentially differing, and I'm happy to have questions or discussions about this. Okay. So the applications for temperature management most commonly are in neonatal birth injury, cardiac arrest resuscitation, which has gotten a lot of attention over the last 20 years, and then acute CNS injury. Probably most of the data are in patients with traumatic brain injury, and we're going to go over some of them and original studies, and then some of the more recent trials. But there's literature that is covering, hypothermia during aneurysm surgery, and then, as you all are aware, the spinal cord injury patient population is very interesting, and hopefully something that will be desirable and helpful for our patients. Okay, so TBI, you all know, very important problem in the United States and the Western countries. It's the fourth leading cause of death in the US. Very common. We see a lot of it here. And, in cardiac arrest, which is the other population that we'll be talking a lot about, it is the #1 cause of death in the United States. So the two main areas that we're going to discuss as far as acute brain injury and the application of temperature management are the #1 and #4 causes of death in the United States. So this is important stuff. This is common stuff, and this is something that will touch all of us, either personally or professionally, or probably both. So survival of out of hospital cardiac arrest in 2015. Anybody want to take a guess? Any of the residents? How many people who have a cardiac arrest out of the hospital survive? Is it like 50%, 10%, 30%? Anybody? I'm going to look and see who's here. Tyler, you're the first person I saw, or Damien. Come on, anybody, take a guess. All right, it's less than 6%. So 94% of people who have a cardiac arrest out of the hospital will die. So we're talking about a pretty poor starting point. And this is not, 30 years ago. These are data that are published in 2015. What about if you have a cardiac arrest in the hospital, right? So we take care of these patients. Come on, take a guess. Is it 50% live? Is it 30% live? What do you think? Nobody wants to guess. All right, it's 24%. So just about a quarter of the people who have a cardiac arrest in the hospital live. So we don't have a handle on survival yet even. So everything that we can do to try to help these patients is actually quite meaningful. And the determinant of survival after cardiac arrest is often not cardiac. Sometimes it is, but a lot of times it's neurological. Most of the time it's neurological. And that comes to fruition through withdrawal of life support. So patients who have alterations in consciousness after a cardiac arrest or after TBI end up having a much higher chance of having us withdraw life support. And that's a whole other talk and something I touched on when we discussed prognostication. But acute brain injury is a really important target if you want to think about survival after these diagnoses, right? So if patients wake up, you're much less likely to withdraw care on them, right? And that just kind of makes sense. The way that we measure acute brain injury in a functional way after cardiac arrest is through the Cerebral Performance Category Scale. It's a CPC scale. You may hear me talk about this a little bit later. It is fairly analogous to the GOS, the basic GOS, which is a Glasgow Outcomes Score, or the Modified Rankin Scale. The Modified Rankin Scale and the Glasgow Outcome Score are scales that we use more commonly with acute brain injury, TBI, and stroke. And so depending on which population I'm talking about, these studies that are published will look at functional outcome with one of these scales. And that's a really important point because functional outcome is really what we're interested in. Mortality has been used and survival was what I just talked about to look at the success of our treatments. But the truth is that nobody really wants people to just survive. We really want to preserve neurologic function in patients who have brain injury, either through TBI, cardiac arrest, or some other acute process. So here are some of the trials that have been published over the last 20 years. These are cardiac arrest trials. There's been a lot of focus on this population as far as temperature management is concerned over the last 20 years. Part of it is that there's a lot more people who die of cardiac arrest than any other population. As I mentioned before, it's the #1 cause of death in the United States. And then, there were also, it was nice to have something that you could do, because I think prior to this, to these trials, patients who had cardiac arrest were often thought to not be viable. And certainly if they didn't wake up right after you got return of spontaneous circulation, people kind of assumed that there was nothing that you could do that was going to help them. And so I think that a lot of these earlier trials, these two trials that were published in the New England Journal in 2002, actually, it was the same journal issue, really were game changers. It caused a big transition. And these two trials you've probably heard of, the Bernard trial and the Haka trial, were very small trial. They had a lot of bias. They had some, now many people have gone back and looked at what some of the problems were with these trials, but they were really big news at that time. And what they looked at was if you provided temperature control and cooled patients after recovery of spontaneous circulation, you could improve survival to hospital discharge as well as functional recovery after cardiac arrest. And this really caught on very quickly and really caused a transition in care. And I think people started to focus on this population. We started to do more for them. We started to resuscitate them more completely and to take care of them more aggressively in the early phases after recovery from cardiac arrest. And that really led to, I think, improvements in our care processes and in outcome as well. Then there were sort of these next set of trials that were published kind of from 2010 through 2018 in cardiac arrest. And, you know, most of these trials looked at, okay, there were some problems with the initial trials. Maybe they weren't very well controlled. Maybe they were too narrow. Maybe they weren't big enough. So these were bigger populations. They looked at what the specific temperature should be. Should you cool people to 32, to 34? Did it matter? Later trials looked at 36 and then looked at the duration of cooling. These were all things that we thought might make a difference. And then more recently, people have started to look at hypothermia versus normothermia. And what I'll say is that second group in the 2010s to 2018, they did not show quite as robust improvement in the experimental group. And the subsequent trials, the TTM trial, which we'll talk about a lot actually, that was published in 2021, really did not show any difference. So we went from a very optimistic position in 2002 to a more difficult position in 2021, where we're not really seeing the improvements in functional outcome that we had expected to see, certainly not 20 years after we started implementing these treatments. So sadly, something similar can be said about traumatic brain injury. So if you look at the initial trials, Don Marion did a lot of work that was published in the late 1990s. 1997 is this initial single center randomized controlled trial of hypothermia after traumatic brain injury. And, you know, he showed improvement in mortality as well as functional outcome and had good p-values. And this was, you know, everybody was super excited about this. And, you know, I think that people did, certainly academic centers did sort of accept this and start to try to implement it into their clinical care. Subsequently, others also did randomized control trial. These were single center and then moved on to multi-center. And what you can see here, the 2001 Guy Clifton trial, which was multi-center, did not show a difference in neurologic outcome. And then when you go to even later trials that were also larger trials, multi-center and randomized with a broader population, we did not see those improvements in outcome or mortality in traumatic brain injury patients. So this made many of us kind of take a good long look in the mirror, right? So, you know, you're really excited. For me, it was like at the beginning of my academic career, I was really thought this was going to be the thing, you know, that was going to change our outcomes and our practice. And a lot of people put a lot of time. And so it's very disheartening to kind of feel like the more we studied this, the less we saw as a potential benefit. And so, you know, I think that's really what we want to talk about. Like, how do you process these data and the fact, and these are very well executed large trials in both cardiac arrest and traumatic brain injury that are having similar outcomes. So how do you make sense of that? So we got to go back a little bit to the science, and hypothermia is super sexy to think about because it has so many different potential ways of improving patients who have acute brain injury. This is a little schematic to kind of show you that, but it affects all of these cellular and metabolic processes: energy metabolism, blood-brain barrier disruption, oxidative stress, apoptosis, inflammation. I mean, it looks like, you know, like you really should hit it out of the park with this. And this is a picture that Ross Bullock gave me years ago, but this is what we're trying to avoid, right? This is a TBI patient with horrible, cerebral edema post TBI, and I think that anybody who's seen this in the OR understands why this is such a target. How can we decrease all of the badness that happens in the patient's brain acutely after injury to try to improve outcome and try to affect this process that you see here so clearly. So if you look at the science of therapeutic hypothermia, this is a little schematic that kind of shows you how this works. As your temperature goes down, which is here on the x-axis, your CBF, you can see the line, the higher the temperature, the higher your CBF, the lower the temperature, the lower the CBF, and the oxygen consumption follows suit as well. So when you are warm, you have high oxygen consumption and high cerebral blood flow. And when you're cold, your oxygen consumption and cerebral blood flow go down. And what this translates to is that your intracranial pressure goes down, right? And so physiologically, this completely makes sense. As long as you have some metabolic coupling, ICP is affected importantly and meaningfully by cooling. And I think any of us that have taken care of these patients knows that this is true. And all of the randomized control data in the world are not going to convince me that this is not true, because I've stood at the bedside of enough patients who have an ICP of 30 when their temperature is 38.5, and who have an ICP of 15 when their temperature is 36.5. And that is because of this physiology. So I think how does that happen? So a lot of people have spent their entire careers trying to understand this and think about it and look at it. This is a study that was published in 2012 and really tells you that if you happen to be a pig, therapeutic hypothermia is definitely good for you. This is a pig study that was published looking at hypothermia after cardiac arrest. This is my favorite organelle, the mitochondria that's here. And what they did was pretty straightforward. They took these pigs, they gave them VFib arrests. They arrested for 8 minutes, and then they did CPR, and then they introduced cooling after CPR. So it was a very clinically relevant model. They cooled for 4 hours. They started cooling for 4 hours. They cooled continually for another 12, and then they rewarmed for 8. And then they did euthanasia at 2 points, looked at histology, and then they looked at functional recovery scales as well. And they also looked at different molecules that function in the mitochondria, the complex 1, complex 3, and some superoxide dismutase. So looking at oxidative stress and mitochondrial function. The control arm is all the way to the left, which is labeled BC, and you can see that the hypothermia group, which are the dark columns over to the right, really do attain fairly good recovery of all of these mitochondrial components, after 72 hours, if they receive hypothermia. And so, this was very, very exciting. And we thought that, this was going to translate into better functional recovery. If you look at histology in these pigs, this is normal mitochondria. These are the mitochondria after, can't remember, these are 24-hour histology sections that have some preservation of the normal mitochondrial structure after therapeutic hypothermia. And then over here where the normothermia group, that you could see that there's disrupted mitochondrial structure. So knowing that pigs did so well, we really expected that people were going to do better, right? So why didn't people do better when we started looking, especially in the more recent trials with hypothermia and normothermia? Why weren't we seeing functional outcomes that were consistent with that histology that I just showed you that really should translate to something better? So back in the early days, these are the papers that were published in acute brain injury populations that really showed clinically that patients who had fever did poorly. And none of these are randomized controlled trials. They're usually single center experiences. Some of them are retrospective. So the quality of these data were not excellent. However, it was very consistent across different groups. The three that are here are Columbia, Harvard, and WashU, and they looked at different populations, subarachnoid hemorrhage, TBI, and all of them found the same thing, that patients that had fevers with acute brain injury had poorer outcomes, higher mortality than patients who had less fever burden. And so there was some clinical signal there that temperature was really important for patients with acute brain injury, and that this was an important thing to focus on. And so I think all of us that have done the work of taking care of these patients kind of had skin in the game and really had a reason to try to believe in this. And so I think that is what has motivated people to continue to study this and not abandon it. In cardiac arrest, the TTM group from Europe published a much larger trial than the initial studies in cardiac arrest in 2013. This was also published in New England Journal, and it was a really good study. It was 950 patients who they achieved ROSC after cardiac arrest, but did not follow directions. Their GCS was less than 8, and they had out-of-hospital cardiac arrest. And the two groups were cooling for 24 hours to 33 degrees or 36 degrees. And they really did a good job of trying to control withdrawal of life support and prognostication. They really looked at all of the variables that could have biased the earlier studies, really trying to do a better study. They excluded anybody who was unwitnessed or arrest with asystole, and so they really tried to look at a more realistic population. This is an example of the two patient groups. They were cooled to their appropriate targets. So it looked like they were able to accomplish what the protocol required. When you look at their outcomes, the survival curves over here on the left, really pretty much the same. So there was no statistical significance in survival or functional recovery, cerebral performance category, in the two groups. So, I will say that if you look at the functional recovery and survival of the whole study, both groups did better than the original 2002 trials. So in general, the level of clinical outcome had improved. It's just that we weren't seeing the difference between the two groups, the hypothermia and the control group. The other thing that we kind of got from these data is, if you want to look at what one of the more important variables was for good outcome, it's the time to ROSC. So this is a little curve that shows you odds ratio of a good outcome. So, this is your odds ratio of a good outcome, and down on the x-axis is your how long it took you to come out of ROSC, and basically diminishing returns at about 20 minutes, right? So if you look at the entire population, the thing that's most important is that somebody defibrillates you or resuscitates you, and you achieve ROSC before 20 minutes, and that is probably more important than whether somebody cools you afterwards. And we'll have a case a little later that kind of speaks to this point. This is out of hospital cardiac arrest. The curves are probably a little bit different for in-hospital, but not that drastically different. So then subsequently, 2021, same group said, okay, I want to look further because maybe the two study groups in the previous TTM trial were 33 and 36 degrees. So now they said, okay, well, what about real normothermia? Like goal of 37.8. So just try and keep them under 38. Does that make a difference? People really were trying to find a positive signal here. And this is the temperature curves. Again, the patients will, they were able to accomplish what they set out to accomplish. The control group, which is in red here, were pretty much on target to be below 38. A few of them, if you look at the standard deviation bar is a little bit higher, but really not, these people were not wildly febrile. And then the TTM group really got down to 33 pretty consistently. And the two groups, each of them had over 900 patients. They were pretty well matched for age, for other comorbidities, for the time to ROSC. The groups were pretty well matched. And there was no significant difference in the clinical functional outcome or the mortality for these groups. And a lot of people have taken this study to represent the idea that therapeutic hypothermia is not helpful. And I don't think that that's true, but certainly it made us, especially the old people that have been doing this for a while, really try to figure out what is going on, because A, we didn't like the results of the trial, and B, we still feel that there's a benefit somewhere. So trying to understand why we keep seeing these trials end up negative. So when I looked at those curves that I just showed you from the TTM2 trial, it made me think of the initial articles from 2002. This is the same curve from that 2002 HACA study. And I was like, wow, it looks very similar. The normothermia group really wasn't that different than the normothermia group in the 2022 trial when you actually look at the curves. But why were the outcomes so much different? Like, why are we seeing, there must be something else, right? So maybe TTM is not the only signal that really is looking at outcome. And so, why did we see such a difference in the survival curve in the 2002 study, but not in the 2022 study? So I think part of that has to do with, our general care for these patients has improved over the last 20 years, which is good. And this is a figure from a recently published paper looking at all of the things that we do for patients with cardiac arrest, 2006 versus 2017. The red line is survival, but like the orange line is brain CTs, and these other lines are TTM and protocolized care. And so in general, over 20 years, we've really improved the general care of these patients by paying attention to them, by focusing on them, by feeling that they, by being more optimistic about their outcome, by not being nihilistic. And that has elevated their outcomes in general, and certainly their outcomes in the setting of a large clinical trial. If you look at sepsis has been pretty flat, actually. So I wouldn't say that it's just that critical care or that, medicine has gotten better. I think it does have something to do with the diagnosis, right? So as much as we've put a lot of money and interest and time and regulation on sepsis, we really haven't moved the needle very much on sepsis, but we have on some of these other diagnoses with acute brain injury. The other issue that's probably important is looking at the community versus a study. So especially those early studies were very much focused populations. They only included people that they thought were going to do well. It was a highly selected group. It really was not representative of all the people that we have coming into the ER with cardiac arrest, or all of the patients coming in with traumatic brain injury. So this is an example of a more recently published study that's actually looking at cardiac arrest in the community. This is the Heart Rescue Project. It's multi-states. You can see Arizona, Minnesota, North Carolina, Pennsylvania, Washington. And they looked at registries of cardiac arrest. And so it's really trying to get the pulse of what's happening in the community, in registries, in the real world, not just in these very focused, very highly controlled studies. And then they looked at the entire 65,000 patient data cohort that had cardiac arrest from a presumed cardiac cause. So not people choking on hot dogs. We're really looking at people who had an MI or a STEMI and then had a cardiac arrest. And then they took this very select group, 10,000 people who were bystander witnessed with a shockable rhythm. So in the cardiac world, like this group is the best prognostic group possible, right? So it's people who you think you're going to reperfuse quickly, who had a known cardiac arrest time that was witnessed. Hopefully some of them got bystander CPR. Probably if they were in Washington state, they did. Not sure about the other states. But really this group was really expected to do better. And so when you look at these data, the red square is around that 10,000 person group that's expected to do better. And if you compare it to the group to the left of them, they did do better. If you look at how many of them get discharged to home or even survive to their end of their hospitalization, which is on the top there, they actually do better. It's about survival to discharge in this group is 34% compared to in the greater group, which is still around 11 to 13%. So in general, we are able to select the patient group that should do better. We are able to give them treatments that improve their outcome. And we are able to do a little better than we were doing certainly in 2002. If you look at the trials, the more recent trials, these are the recent cardiac trials, and you look at survival with good neurologic outcome, which is CPC scores, those cerebral performance scores, which really show recovery of function, people who are able to go back to their daily lives. They may not work at 100% the capacity that they did before, but they can work with some accommodations. It's almost half of the population in these studies. So first of all, that's not representative of what's happening in the greater population, in the greater community, but it also represents a very big improvement to where we were 20 years ago. So I think part of the problem is our own success in improving general care, that now we're not showing the improvements in the experimental groups for these TTM trials. So what about TBI? As I mentioned, the earlier TBI trials in 1997, I think it was, for Don Marion's trial, and then Guy Clifton's trial, they were more positive as far as your outcome measures. But the more recent trials, I think the lower one here, the Cooper one, is a large multi-center trial that was out of multiple countries, New Zealand, Australia, Switzerland, and had a larger population, and really didn't show a difference with therapeutic hypothermia in TBI when you look at mortality or outcome. Now, one of the things with these TBI trials is that most of them had protocolized hypothermia for patients with a certain GCS. So their GCS was less than 9. And they started therapeutic hypothermia within a certain time from their acute injury. So most of them started, within the first day. And then the time that they were treated with hypothermia was usually 24, but 48 hours. So for those of you that take care of TBI, you know that when you're looking at that 2 and 3 day mark in these patients with severe TBI, many of these patients are just starting to have brain swelling. or they're having worsening of their brain swelling in that time window. And that was exactly when rewarming was starting to be performed in these patients. So a lot of these trials for early hypothermia, which seemed to work very well in the pig model, was not panning out for people. And I think that if you look at the complications, yes, there were systemic complications. There was a lot of pneumonia, there was hypotension, there were electrolyte disturbances, there were some arrhythmias. But a lot of it was that these patients had refractory ICP as you were rewarming them, because you were rewarming them on day 3. So there have been a couple of, single-centered, mostly patient series looking at, well, what happens if you cool them for 2 weeks, and then you avoid that. It's possible, and you probably do treat ICP better, but you have a whole slew of systemic complications, ileus, hypotension, infection, arrhythmias, electrolyte disorders, if you cool these people for longer. So really the complications end up being, in my opinion, what imbalances the outcomes when you look at functional outcome and mortality, is that you start to accrue all of these systemic complications when you apply hypothermia to these very sick patients indiscriminately. And I think that's probably why we're seeing the lack of positive outcomes in these later trials. So the Eurotherm trial, which Peter Andrews published in 2018, took a little different perspective, right? So they said, okay, well, what if you don't just give everybody hypothermia after TBI? What if you just look at people who have elevated ICP? So this, on the left side, is their protocol. And what they did was they looked at people with severe TBI, GCS less than 9, and they said, okay, if you fail the first tier of treatment for ICP, so like head of bed elevation, some osmotics, then we use TTM, then we use hypothermia, and we cool you to 32, 30, 35 for the target treatment group. And there's a protocol for that, and then maybe that makes you better. They enrolled 387 patients, which is actually a fairly reasonable size for a TBI trial. It's hard to enroll these patients, as you all know. 47 centers, 18 countries. And they found that, yes, you were able to make your ICP better, but in general, the treatment arm had a higher mortality and worse functional recovery. So everybody felt pretty down in the mouth after this was published. And again, we are looking for why. And so this is a more recent publication, or actually this study, which is the Polar study, looked at looked at 500 patients, and they had TBI, and they treated them with hypothermia or normothermia. You can see that they actually attained their outcome measures. They looked at intracranial pressure. They really tried to understand, where the benefit could come, and it was a larger trial. And at the end of it all, if you look at the Glasgow outcome scale bars at the bottom, they had their outcome measure was GOSE 5 to 8, which means that's lower end of moderate disability all the way to the upper end of good recovery. And those are people who are actually can be left alone for long periods of time. The 5s and 6s are probably not going to go back to work, but they're able to have reasonable quality of life with their family. And depending on how severe their injury was, these are people that you would expect, you would consider to have a good outcome. And then they also included the people here on the lighter colors in the bars that went back to work. But the bars are pretty much the same. And so they really weren't able to show a difference. And actually there's maybe a little more mortality in the hypothermia group. So here's yet another study in TBI that was well executed, big population, well balanced, and wasn't showing us these benefits. So last year, a group tried to look at the data and do a post hoc analysis and say, okay, well, maybe maybe all these studies are not doing enough to cool the patient. So one of the downsides of including lots of people in your study is that not everybody can do therapeutic hypothermia well. And I think that that's been our experience too. If you are in a place that does temperature management well, then you do it maybe more consistently. You know how to manage the side effects. You know how to cool to the target better. And so they created a cooling index. So a way, and you can see that they have an equation. Actually, they have an equation. Oh, here, let's see. To estimate the coin, which they call the cooling index, and it looks at the duration of cooling, the rate of rewarming, and how cool the patients got. And then they looked back at all of the studies previously and said, okay, who did it well? They said, okay, there's a low, a moderate, and a high. And so of all these different studies, some of these studies did better than others. And then they looked at a forest plot after that. So this is really, really trying hard to try to figure out which people do this work better and which patients can benefit. And they were able to say that if you do it, if you find patients that have a high coin index, basically these patients are the ones that are expected to do the best. They're the equivalent, I would say, of that group, that 10,000 patient subgroup in the registry that had shockable rhythms and that had a witnessed arrest. Those people maybe were able to benefit a little bit. The odds ratio looks like it's pushed a little bit that it favors hypothermia. But as you can see, a lot of these confidence intervals cross one, and the data are not overwhelmingly positive, even with this effort. So what do we do at the bedside? This is a patient that many of you probably took care of. This is a 42-year-old man who was admitted for an intramedullary spinal tumor resection in July, recently in the ICU. I thought it was a good example for what do we do? Like, we have all this information, we now have all this knowledge, we have all this conflict, but we also have like our own experience and what we believe to be at the bedside. He had a history of a DVT, he had an IVC filter previously placed, he went into the OR, had his tumor resection. He was started on enoxaparin post-op day 1. Everybody's, crossing the T's, dotting the I's. He had some leg swelling and complaints, and post-op day 2 got an ultrasound showing that he had complete thrombosis of both of his femoral veins. And then basically the next day was found unresponsive on a step-down unit with a PEA arrest. Had 2 arrests. The first one was 20 minutes, the second one was 30 minutes, and during the second arrest got TPA. Despite his recent surgery, because basically he was trying to die over and over again. And then he was taken to the ICU. This is his initial postcode head CT, which looks fine. So you wouldn't expect to see anything acutely with respect to acute brain injury, but we just, you have to make sure that he didn't bleed with a TPA or anything unexpected like that. And then he came to the ICU. He got a heparin drip, and he was in shock. He was on 3 pressors, and looked really, really sick. He had hypercarbic respiratory failure. He had presumptively a very large PE with hemodynamic consequence to that. His echo had poor windows, but he was showed to have right ventricular hypokinesis and higher filling pressure. So this is consistent with a PE. The clinical scenario was consistent with a PE. And he had altogether over 50 minutes of cardiac arrest. Now, the good thing is that he tried to die in the hospital. And so he got CPR pretty much from the beginning, which is not what happens if you die at Publix. And so overall, his prognosis should be better than out of hospital cardiac arrest, but still at 50 minutes of arrest, that's really you know, a concerning number. And certainly if you go by the graphs that I showed a little bit earlier, you know, you're way out more than 2 standard deviations from the mean if you look at risk, you know, expectation of good outcome. So would you guys cool him? Anybody? You're a quiet group this morning.
Yes.
Thank you. Yeah, I figured you would. So we did. This is his temperature curve. You can see, and what this tells me is that we're good at doing this, right? So we know how to do targeted temperature management. The nurses are fantastic. They get the pads onto patients quickly. We know how to choose patients. And when we cool them, we actually do cool them. Like we don't mess around. And you can see how quickly this patient's temperature got down, and it went down to you know, the expected level, and then he was slowly rewarmed. You know, and he had a complicated ICU course. He had a lot of pulmonary problems. You know, what I understand, when I saw him, he was starting to wake up, and I spoke to the intensivist that took care of him the following week, and he had preserved cognitive function. And, you know, I think that this sort of shows you that we have to treat individual patients, and you cannot make all of your decisions based on a 1,000-person trial or a 10,000-person trial. You need to take that information into account, but you always have to apply it to the individual situation and also your individual environment. If you're in an environment that can do something you think better than you know, the great majority of places, then perhaps this tool is going to have better outcomes in your hands. So this is a similar case that we took care of in the TBI population. This is Dr. Jagged's patient, I think from several years ago, that, you know, we also used temperature management. And you can see this patient has a very severe traumatic brain injury with a depressed skull fracture, cerebral contusions. He, you know, was young, 18 years old, no helmet, and got the full court press, you know, that he came in, he got surgical management, he got monitoring, he had, you know, very aggressive ICP control, had a bed elevation, his position. And this is sort of how we think about our treatment, right? It's not, hypothermia is not the only thing we do. We do a lot of other things, surgical and medical, CSF diversion, osmotics, temperature control, paralysis. Our algorithm includes many things, but temperature adjustment is something that we do once other things are not having the effect that we want, right? So many of you have seen us do this. We do not routinely, actually, we don't cool down to 32 or 33 the way we did maybe 10, 15 years ago. Most of the time for the TBI patients, we will just go down to 35. And that's usually sufficient to bring the ICPs into a controlled window for the time that the patients are swollen, and really give them a time, an opportunity to improve and to recover, actually, is what I should say. So my conclusions from this can be summed up that, you know, therapeutic hypothermia is a tool. It is not the answer to every problem. If your plane has an emergency and it's on the ground, a parachute is not going to help you. If you happen to have a plane problem at, you know, 10,000 feet, a parachute will be very, very helpful. So part of our ability to care for these patients well and to give them a good outcome is to know when to use which tool. And I think part of the problem with these very large randomized control studies is if you take 10,000 patients or you take 1,000 patients with a particular diagnosis, it is extremely difficult to select only the ones that are going to benefit the most from the tool that you're studying. And I think that has been the great challenge for evidence-based medicine in the last 20 years, is that we know that not all patients are created equal, and not all patients will benefit from the tools that we have to the same extent. And so I really believe strongly that if we have patients that can benefit, we need to know how to use our tools in an intelligent fashion and to select our patients well. So that's all I have. You actually have a couple extra minutes, and I'm happy to take questions about this if anybody has some.
No, a terrific job, and I couldn't agree with you in terms of your interpretation of the literature. But it is a quandary for us, you know, without large scale prospective randomized trials, you're not going to convince, you know, the University of South Carolina or anyone to do what you think is right. And so my question is, since the 2021 negative trial for cardiac arrest, have they pulled that out of the you know, the cardiac, you know, the, what do they call it? The ACLS cardiac protocols, have they pulled it out?
Right. So one of the frustrating things, and in this case, actually one of the, I think, helpful things is that guidelines and recommendations always lag a couple of years behind publications. So nobody has changed the cardiac, like the ACLS guidelines. There's still post-resuscitation recommendations for temperature management. I think people are being a little bit more flexible about what the target temperature would be. And the AHA guidelines for cardiac arrest have not changed yet. I will tell you that I do sit on the DSMB for the Siren network, and there is a very large multi-center cardiac arrest trial called ICECAPS, which is going on right now, many centers, and it's looking at multiple arms, multiple durations of cooling, and multiple temperatures. And there was a lot of discussion about continued funding versus not after these studies. And I think overwhelmingly everybody in the academic community feels like we need to push forward and to really look and see if we can identify which patients can benefit. And so there is continued support to investigate and to fund this kind of work. But I do think as far as trying to figure out how to have it be implemented in the community and how the guidelines will change, you know, especially if ICECAPS ends up being negative, my guess is that the guidelines will change, and that certainly the level of support for the recommendation for cooling will be changed. I don't think anybody wants to go back to the way we were, though, in you know, 2000, where people were just wildly febrile. I really do think that we will continue to aggressively treat fever. There's actually another trial called the Intrepid Trial that, again, like I said, hopefully will be published in the next year, that's looking at acute brain injury and normothermia and avoiding fever. And I'm hoping that we'll see a benefit there, because I do think that that's important, and that really should not leave our practice of patients with acute brain injury. And, you know, I mean, the application to spinal cord is an important point, and I don't think that a lot of people kind of think about that as much. And so, you know, that work is very important as well, because there's no reason to think that that it would be less impactful in that population.
Thank you.
Can I ask a quick question?
Sure.
I remember in the early TBI studies, sorry if I missed this point, which I very well could have because I was gone for about 7 minutes, but in the TBI studies, they were saying that hypothermia was beneficial for the subdural population. And then there was the HOPE trial. I don't know if that ever came to, you know, fruition, or what the status of that was.
I remember that it was the Texas group, right? I don't know if it's been published. I think that people have tried to look, that Cooper study, the Polar study is a 500 patient study, and people have gone back to try to look at subsets of patients with different diagnoses. And that's where they came up with that, you know, coin index and stuff. I don't know. I think that most of us believe that there are subsets of patients that can benefit, but I don't know that people have found that subdural specifically stands out as one.
Yeah, I ran into Ryan Kitagawa about a month ago, and I asked him about that. It was Dong Kim who got the money, and essentially the trial is not recruiting patients. That it was, I think he said it was a negative trial, but incredibly small trial, and that they published it in some obscure journal. So you may want, I didn't look it up, but it's apparently out there.
Got it.
Try not to be too depressed about it.
We were enrolling in for that very briefly. But
Yeah, but I mean, again, like, I'm an optimist, but I do think that part of it is the way we study these things, and the physiology is really solid, and we see it clinically in an individual basis. And so I don't think that we can abandon those things that we know to be truths. And I think we need to know how to apply that in a way that we don't harm patients, right? Because I think you cannot apply this therapy to just every single patient that has a TBI, that comes in. I do think that patient selection is really important.
But thank you again.
My pleasure. I will go over to the unit, and hopefully your next speaker's here. See you later.
Okay, awesome. Yeah, so my name is Luke Mcvay. I'm a visiting sub this month from Indiana University. First, I just want to thank everybody for having me this month. It's been an awesome first 2.5 weeks, and definitely looking forward to the last week and a half here and finishing strong. But today, I'm going to give a presentation on one of my prior projects titled Spinal Column Shortening for Secondary Tethered Cord Syndrome, the Radiographic, Clinical, Eurodynamic, and Patient-Reported Outcomes. And this was a project conducted with Dr. Andrew J. When he was at IU. He since moved to Oklahoma, and he's a fellow residency graduate, so I think many of you are familiar with him. So first, just a little background on tethered cord syndrome. The pathology, it's a disease caused by an aberrant spinal cord attachments, typically in the lumbosacral region, which leads to a pathological longitudinal stretch that leads to progressive neurological dysfunction, typically presenting as pain, weakness, skeletal deformity, as well as bladder and bowel dysfunction. And so the traditional treatment for this and the gold standard for quite some time now has been a tethered cord release procedure, in which you manually go in and lyse any of the abnormal attachments that are tethering the cord. And this is a very effective procedure. The clinical outcomes are very good, especially relieving symptoms. However, there are some significant shortcomings, more specifically a very high rate of retethering and recurrence, especially with more complex pathologies, such as myelomeniingocele have been shown to have 3 to 32% retether rate, as well as lipomyelomeniingocele have upwards of 40%. Additionally, there's been shown to be diminishing returns with each additional tethered cord release that needs to be performed. As you can imagine, when you enter into the dura, it creates a scar tissue from the lysing the previous adhesions, and this can lead to recurrent scar tissue and also distorts the anatomy. So each additional procedure becomes more and more difficult with a higher risk of retethering again. So you enter into this vicious cycle of many retetherings. So a potential solution to this issue, it was originally proposed by a Japanese surgeon actually back in the late 90s, but it's spinal column shortening, which the theory behind it being that instead of entering into the dura and lysing all the adhesions, you instead shorten the spinal column around the spinal cord so that this shortens the distance that the spinal cord is stretched. So this allows you to alleviate the tension on the cord without requiring entry into the dura. And this is thought to be especially applicable for more complex pathologies and recurrent cases. So there's a few different techniques that are used to shorten the spinal column. And the one which Dr. J utilizes is 1.5 centimeter 3-column vertebral column resection. So it requires a laminectomy, removing the facets and TPs bilaterally, and then drilling into the pedicles and kind of reaching around to reach the drill out the vertebral body. And then usually a down pushing curette is used to remove the last ventral portion of the vertebral body. And this allows for the end plates to be left intact and does not require any disc resection. Additionally, allows for a straight closure when it's compressed down. It does require a 5-level instrumentation with 2 levels above and 2 levels below the osteotomy gap. It's typically performed at the thoracolumbar junction, as this is the area with the least curvature of the spine, as well as the least consequential nerve roots in case there is an inadvertent nerve injury. Here's just an example of one of our patients pre and post-op, a 19-year-old female. And you can see here just about a 1.5 centimeter vertebral height reduction. So to look into this, it's the outcomes of this procedure are not well documented, as it's a pretty rare procedure performed. So we wanted to perform this case series of the patients treated at Indiana University. And so we wanted to determine the safety and efficacy of spinal column shortening for secondary tethered cord syndrome in children and transitional adults. Transitional adults being patients whose disease started in childhood and they have since transitioned into adulthood. So our case series included 41 patients, 30 of which had at least 12 months of follow-up, so they were included for clinical outcomes. And this is the largest case series to date on this topic. So as far as our outcome measures, first, we wanted to look at the radiographic outcomes to assess the spinal fusion at 12 months, and this was done via CT scan. Additionally, we looked at clinical symptoms, subjective clinical symptoms, which we reviewed via chart review retrospectively. And we primarily looked at the symptoms of pain, weakness, and bladder dysfunction. And we looked at a presentation and then at the most recent follow-up that we had. The bladder dysfunction was defined as leakage between catheterizations, febrile UTIs, and social incontinence. And of note, these symptoms that we recorded were only the presence or absence of symptoms. So unfortunately, we didn't look at any gradation of them. For our patient report outcomes, we utilized the PEDS-QL questionnaire, which is a generic quality of life assessment for children. And so for patients ages 8 to 18, it uses both patient and parent reported scores, and for patients under 8, only parent scores are used. And lastly, we did look at urodynamics in conjunction with our urology colleagues. And so they categorize the urodynamic parameters of like max bladder capacity, max flow rate, and categorize them using the National Spina Bifida Patient Registry renal protocol into either normal, safe, intermediate, or hostile bladder conditions. And this was done by 2 of our urologists at IU. And then this was performed only at pre-op and then at 3 months post-op, and then whenever clinically indicated, because it is a pretty invasive measurement, especially for children. So as far as our patient demographics, the average age was just about 16 years old. However, we did have quite a few young patients as young as 5. Gender distribution was fairly even. The mean follow-up was just about 22.5 months, with the most common tethered cord etiology being myelomeningocele. And the average number of prior untethering for our patients was 1.8. As far as our operative data, the most common level of the osteotomy was at T12. The mean operative time was just under 4 hours, although a pretty big range with just about 2 hours, upwards of 7 hours. And this operative time did decrease throughout the series as surgeon experience increased with the procedure. There was a significant amount of blood loss with the procedure, averaging 662 cc's. Hospital stay was 5.1 days. As far as operative complications, there were 2 patients with acute blood loss anemia and 1 with a small durotomy, though no post-op CSF leak was seen. Additionally, there were no complications of new neurological deficits, CSF leaks, wound infections, or death in the series. So as far as our outcomes, the radiographic outcomes were measured at 12 months. So 30 patients were included, and all of them showed solid arthrodesis with proper alignment at most recent follow-up via CT scan. For the subjective clinical symptoms, again, needed 12 months of follow-up. 23 patients had preoperative pain, of which 91% showed resolution postoperatively at most recent follow-up. 24 patients had lower extremity weakness, of which 2/3 had resolution at most recent follow-up. And then 29 patients had some sort of bladder symptoms, of which 51% showed resolution. For our patient reported outcomes, so these patients needed 12 months of follow-up as well as a pre and post-operative score and be under the ages of 18. Unfortunately, we didn't have any quality of life measurements for adult patients. So this limited us to 19 patients in this. The patient reported scores did show a statistically significant median improvement of +5 on the 100-point scale. with 57% improving past the MCID, 26% remaining in this around the same range, and then unfortunately 16% showing a worsening in their score. Similarly, the parent scores also showed a +5 improvement, although this was not quite statistically significant. 52% showed improvement, 31% remained the same, and 16% worsened. Lastly, our Eurodynamic Outcomes, again, needed pre and post-operative scores, and this limited us to 17 patients in the series. They did show a median improvement of one of those classification categories I mentioned earlier, with 58% showing an improvement of at least one category, 35% remaining in the same category, and then 6% showing a worsening to a lower category. So key takeaways from this, Russ. First, showed that spinal column shortening is safe. There is no reported significant complications or reoperations needed in our series. Secondly, the subjective clinical outcomes showed to be fairly similar to those reported in the literature for traditional tether cord release for recurrent cases. Tether cord release is shown to have upwards of 83% of patients with pain improve, 63% with weakness improve, and then upwards of 56% with urological symptoms improve. So fairly similar ballpark to what we saw with our patients. And the urodynamic results, similarly, were very close to what was reported in the literature for standard tether cord release, which again, urodynamics is a little tough because each institution uses slightly different techniques of measuring this and different ways of reporting the outcomes of them. But they have shown to be about a 50% approval rate for patients. So risks and limitations of this, most notably, I think it's clear is that doing this procedure, which is a major procedure on young children that are still have growing skeletons and have many years of growth left in front of them. So this can cause theoretically multiple complications, including a stunted growth. Typically, you expect 1 millimeter per level fuse per year of growth of height reduction. Additionally, continued growth of the unfused segments could lead to a recurrent tension on the spinal cord. And also you could theoretically have a crankshaft deformity where the anterior portion of the column that's not fused continues to grow, whereas the posterior column remains fixed, and this can add a lot of lordosis. So those are theoretical risks. They have not been observed yet in our patient series. Additionally, we need longer term follow-up. Retethering most commonly manifests 2 to 9 years after tether cord release. So our follow-up is just under 2 years. So obviously we need to continue that to completely rule that out as a risk. The clinical symptoms were subjective in nature. So a more standardized scales would increase the objectivity of these measurements. And lastly, this was not a directly comparative study between tether cord release and spinal column shortening, so that still needs to be determined. Future directions, we really need a high quality comparative study between spinal column shortening and tether cord release. Additionally, long-term follow-up to determine the duration of symptoms or duration of outcomes, ideally 5+ years post-op, as this is the average time frame that a typical retethering would occur. Additionally, the exact indications for patient selection need to be established. Most notably, the timing of surgery. So it's a delicate balance between not operating on a skeletally immature child, but then also if it's delayed and these symptoms are present for a longer period of time, many believe with the longer that the nerves are stretched, the more likely the symptoms are permanent and no treatment will be effective after that. So balancing those two things still needs to be determined. Additionally, the number of prior untethering procedures that should be performed before doing a spinal column shortening, and when and if ever a spinal column shortening can be performed as a primary treatment. So the take-home message, spinal column shortening represents a safe and efficacious alternative to traditional tether cord untethering for secondary tether cord syndrome in children and transitional adults. And here are the references, and thank you all. Any questions? I'm happy to answer any questions.
Hey, Greg Rizzle here. Great talk. I remember, at Tufts University, probably about 8 or 9 years ago, Ron Riesenberger and Dr. Kachansky were looking at this, and I remember looking at those early series out of Japan, and they had several reported cases of cord buckling when they shortened the column too much. And so I remember at Tufts at that time they were doing cadaveric experiments to determine the optimal length of shortening. It sounds
Yep.
like you guys arrived on 1.5 centimeters. And obviously you have had no complications like that in your series, and maybe that's because of the length of shortening. How did you guys arrive at that number?
Yeah, so that we referenced the cadaver studies that show that typically, I think 12 to 16 millimeters is the ideal length, because anything beyond 16, you do run the risk of that dural buckling. But usually if you get it above 12 millimeters, at least what cadaver showed, that was enough to reduce the tension on the cord. So that's kind of how we arrived at 15 millimeters. I do know that there are a few other studies out there that do shorten it more. I believe Hopkins just came out with a study with Dr. Nick Fedor that they shortened it by like 22 millimeters on average, I think. So, and they use a slightly different technique. But yeah, that's definitely something that needs to be pieced out a little bit more too. But so far, the 15 millimeters seems to be a pretty good number, at least for what Dr. J's been doing.
All right, so I'm going to talk about the history and evolution of minimally invasive. So I want this talk to be just a 60-minute kind of talk on, like, boring history, just kind of going back for millennia. But I try to include a lot of philosophical points here, so that maybe contribute to how we got to where we are. So if at any point you feel like you don't agree with me, or that there's a more correct perception of this, please feel free to chime and let me know, because it's all that's the whole point of what I tried to do here. But before we get to get into how we got to where we are, we have to first understand what is the definition of MIS spine surgery, right? So there are a lot of things that could be seen as the definition of MIS spine surgery, right? Is it a smaller, or is it a better looking incision? Is it less exposure? Is it less muscle dissection that you can give you the same visualization of the same tissue? Is it less blood loss? Is it a faster or more efficient operative time, right? Back at the Spine Technology Symposium, Dr. Yurkov talked about this, right? He had that equation looking at time of surgery, right? So is a 9-hour microdiscectomy still really minimally invasive, right? I agree with what he said. I don't think so. Right? Is it less anesthesia time? Is awake surgery by itself enough to make something MIS, right? Is it better, faster intraoperative image acquisition that can save time, that can decrease radiation to the OR staff? Having just fewer complications enough to make a surgery MIS? Is it a shorter stay in the hospital? Is it less pain and a faster return to function, a faster recovery, right? And I don't think that there is really one answer to this. All of these define MIS, but at the same time, none of these by itself is a true definition of what MIS is, right? It's ambiguous, it's vague, right? Dr. Wang will say this all the time. It's not just about one thing. It's not just one straightforward answer when it comes to this definition, right? This is what makes MIS spine surgery have such a low barrier to entry, because you can define it whatever way you want, but at the same time, this is what makes it so hard to differentiate yourself in this field of MIS. Every neurosurgeon, orthopedic surgeon, pain management doctor, right, anesthesiologist, physiatrist, you name it, now has their own definition of what they consider to be minimally invasive surgery, minimally invasive spine surgery, right? And so they can put whatever they want out there. And peer-reviewed journals are one thing, right? But unfortunately, you also get this too, right? Every single one of those doctors I mentioned can say they do minimally invasive spine surgery without much of a consequence, right? So, half the residents and fellows, that are on here right now have been to, Wang's clinic and, and have seen, he'll say you're changing the entirety of public perception when you're out there trying to do what's right for the patient, because you have all these other guys that are saying that they're doing the same thing. Some ambiguity in, minimally invasive spine surgery is good, right? Because that's what fosters innovation and drives progress in the field, right? Unfortunately, I clearly definitely don't have the answer to what minimally invasive spine surgery is, but like what James mentioned back in his grand rounds, right? Maybe by understanding kind of where we came from and the evolution of this, we can understand where we're going next and where we're going to take the field, right? Of all surgeries treating pathology with this minimal disturbance of normal anatomy, right? And it's in essence just leaving a smaller footprint. And this is designed by designing procedures with a smaller surgical corridor involving less tissue dissection. And the techniques that enable this are largely driven by advances in magnification, and illumination, and novel instruments that are used. Right? Okay, general surgery. General surgery has embraced this trend. We did a case, with Dr. Sands yesterday. Dr. Sands was telling us, Oliver's there actually. If you ask him, he'll tell you he ended up getting a robot and bringing it to for robotic assisted general surgery procedures. And he said after that time, business just exploded, right? Patients couldn't get enough, he couldn't book them fast enough. And he said that learning robotic general surgery was one of the most important career decisions he's ever made. You can see here, there was a huge rise in the number of cholecystectomies and appendectomies that were done laparoscopically, right? But unlike general surgery, right, where you can just blow up the abdomen with CO2 and you can stick 5 instruments in the belly, right? In spine surgery and cranial surgery, you have to take away normal anatomy if it means you create space for yourself, right? This means you work in extremely tight corridors, and so minimally invasive neurosurgery is not the same as minimally invasive surgery in other fields, right? Like, take the ETV, for example, right? You can't make the ventricles bigger. You can't increase visualization that way. And so in MIS spine surgery, you always have that risk that the smaller you go, the more difficult it is to treat the pathology. You always have a risk of complications from this lack of visualization, right? And for that reason, there are just so many technical advances that can be made in MIS spine surgery. And the key to moving forward is always, to keep an eye looking back. Ancient history, but you have to include one, right? So spine pathology has been around for as long as humans have been alive, right? The procedures to treat this have been around for about 2,500 years, right? Even in ancient Greece and Egypt, right? Hippocrates described a lot of spine fractures, deformity, back pain, radiculopathy. The Hippocratic ladder and board he used to tie and suspend people to forcibly correct their deformity, either with gravity or external force. But moving into modern history, first lumbar laminectomy in the United States was done in 1829 by Albin Gilpin Smith. This was, for a guy in Kentucky that fell off his horse 2 years before. He had progressive weakness and lost sensation in his legs. So he saw 3 parts of the posterior spine that were pressing into the thecal sac and removed those. The guy had return of function. He described his findings in a journal. But the classic first lumbar laminectomy for treatment of spinal stenosis was done in 1893 with, similar to Gilpin, a woman that had remote trauma that had progressive paraplegia for 6 years. Fast forward now half a century, there was rapid progress in understanding for the surgery for spinal decompression, right? The first account of a laminectomy and discectomy to treat radiculopathy was in 1934 by Mixter and Barr. And they did this through extensive removal of a lamina, but actually used a approach to reach the disc. And then they extensively removed the disc material, right? This was standard treatment for disc herniation for some period of time, but as you can imagine, it caused significant morbidity for the intradural approach that they used and the amount of disc they removed, right? So fast forward 5 years now, Love described this technique for interlaminar removal of herniated disc without the need for a laminectomy, just completely through an interlaminar approach. But however, even this surgery kind of went transdural, involved the removal of a lot of disc from the inner space, right? And despite the progress made in spinal decompression surgery, right, from this transdural approach, now not even needing a laminectomy, right, you still have a large degree of collateral damage from the approach and the disruption of the normal anatomy, right? And, sort of going back to the philosophical side, like Wayne mentions in clinic, right, you're fighting a lot of public perception when when these patients step into your clinic, right? It's actually an important point, because, from the psychology of patients. Right, because those perceptions that were created back then pervade spine surgery even today. And what I mean by that is, with those surgeries, the symptoms from the nerve root decompression were significantly improved, right? But at times they were outweighed by the collateral damage that the surgeon produced by actually doing the surgery, right? And so the idea that you go into surgery to treat one problem, but then you come out with a completely different problem, it's a perception that's so strong that, maybe it's even pervaded what patient decision making, what they take into account today, right? And so, like he says, like every, patient comes into clinic with this preconceived notion that they don't want to get surgery. And maybe this is where it came from, I don't know, but this is just, one thought, as to where it arose from. And so, just historically, if the collateral damage was, kind of worse than the surgery itself, then, it's something that can be passed down, through generations. But the Wiltse muscle sparing approach was something that was introduced in 1968, was one of the ways to gain access to the spine in a way that decreased the collateral damage and decreased the pain. Right here, you pass through this muscle plane between the multifidus and the longissimus, and you have a big advantage of the midline incision because it doesn't require subperiosteal dissection off the bone. And once the retractors are in, you don't have that same amount of muscle retraction. And obviously, many of the techniques for decompression, interbody placement, screw, rod instrumentation have gone on to use the Wiltse approach. Was actually introduced to neurosurgery by Yastergill. Right, Yastergill developed neurosurgical. he developed the neurosurgical operating microscope, brought that into the fold of neurosurgical procedures, right? He was obviously known as the father of microsurgery, and many of these neurosurgical procedures were incorporated into spine surgery as well as cranial neurosurgery, right? And sure, the microscope is important, but just visualizing, the tissue isn't the important thing, right? Because you do the same thing with loupes, right? But the actual development of these microsurgical techniques and the instruments used along with the microscope, maybe what I think is the most important thing, right? Because this actually is going to determine what you do in a small space, right? How you use that space, how you move your hands, what sort of instruments you put into that space, right? That is, I think, what really drove this, advancement in minimally invasive spine surgery. And obviously, obviously small incision has less tissue dissection, greater visualization. You have a greater ability to perform something in that space. You have less blood loss and faster recovery, all with that microscope. The first documented accounts of true lumbar microdiscectomy were in 1977 by Yastreville and Kaspar. Right, Kaspar advocated for a midline skin incision, a paramedian incision in the fascia to separate the paraspinal musculature without detaching it. Then he used an interlaminar approach down to the ligamentum, right? And then he made a cruciate into the ligamentum and retracted the dura. Momentum and widespread acknowledgement until later afterwards. In 1978, Williams actually published a report of 532 lumbar microdiscectomies using just a minimally invasive approach with a small incision, minimal tissue dissection, with where he just only removed the herniated portions of the disc, not more of the disc. And he used an interlaminar window that you can see here on the right. Put the patient in flexion, and then once he was down in the disc space, he pushed a pen forward through the annulus and just allowed the herniated portion to come out. So in his symptoms and his results, he found that symptoms improved 90% of patients. Actually, most of his patients were these like Las Vegas showgirls who, for obvious reasons, couldn't have big incisions, had to return to work quicker. The first unilateral approach for bilateral spinal decompression was done, the first dipsy contra was done by Young in 1988. This was followed in the 1990s by McCullough. And the key to this was you tilt the microscope and the patient to actually visualize, to improve visualization on the side. In 1991, Faber and Kaspar in Germany were the first to use a tube to access a lumbar herniated disc. But in reality, this was like a really small tube. This was only 4.6 millimeters, and that was really only big enough for a pituitary. So this was really more percutaneous than truly tubular. But they saw an improvement in 64% of patients. The tubular approach kind of paved the way for further development in this area. But a big reason why the popularity of the tube was limited was initially the high rate of unintended durotomy. Forward came in Memphis in 1997 when Foley and Smith at the University of Tennessee developed this tubular system that could actually house an endoscope and be used in microdiscectomies for lumbar nerve root decompression. So you introduce the tube through the same paramedian approach and dock at the junction between the TP and the pars. Didn't really work out that well with the endoscope initially, and with the more powerful microscopes that were used, they converted that to the microscope. And obviously, this is everybody knows this is the widely used Medtronic metrics workhorse tubular system we all know today, right? But minimally invasive decompression is only half the theory to understand how we got to where we are today, right? The other half is minimally invasive spine fusion, minimally invasive interbody fusion, right? And so pedicle screw instrumentation was first described in 1949 by Michel, but there was a rising shift towards MIS approaches for pedicle screw instrumentation, right? Just based on the amount of paraspinal muscle retraction you need and dissection you need in open approaches, right? There's a big distance from the midline to the TP junction, right, that you need for your pedicle screw placement. And so this can cause, significant paraspinal muscle retraction, ischemia and tissue dissection, especially in larger, more muscular patients. And obviously this amount of dissection clearly causes postoperative pain, and right, it adds significant time to the case depending on how many invasive or start, right? Well, it was born out of minimally invasive fixation. So in 1984, Magriel introduced this technique for transpedicular fixation of the lumbar spine using pedicle screws through a percutaneous approach, right? In his series, he used a total of 4 pedicle screws through the pedicles of the vertebral bodies at, a level, right? Across one level in patients with spine trauma and osteomyelitis. And he found that the results from this were much safer than open techniques. And, in this paper, he didn't really see any serious complications. So this really ushered in, the start of a new incredible era in minimally invasive spinal fusion, right? Now, apart from, benefits of less tissue dissection and post-operative pain and less operative time, you have other benefits with percutaneous screws as well, right? Now, this isn't a picture, really of like percutaneous screws, but I just put it in here to make a point. your entry point of percutaneous screws are at the facet TP junction, right? And they can be a little more lateral with a medial trajectory than your open screws, right? When you bite off the facet. And the triangulation of these screws actually can give you greater pull-out strength, right? Which is important when you're not, when you don't necessarily have the chance to lay down bone graft, right? In addition, because you're not exposing the facets, the facets are preserved at the adjacent levels, right? And so you don't really have, hopefully you have a smaller risk of adjacent segments, right? So Magdarell's percutaneous screws involved rods that were actually placed superficial to the fascia, and they had to go back in a later time and take them out. But the first full percutaneous screw and rod system was the Sexton system that was used by Medtronic, which involved passing an arc-shaped rod through a predefined rod trajectory, right? But the issue was that with this was you could really only use it for short segment constructs, because it was completely set based on the two rods that you put in. So you had to make a separate incision about 3 vertebral bodies of construct to pass the rod to the screws, right? And so interbody fusion has similar evolution when it came to MIS techniques, right? Open access to the disc-based chronology was started by the ALIF in 1933, the PLIF in 1952, and the TLIF in 1982, right? And in 1933, Liu introduced the first method of percutaneous dorsolateral interbody fusion, right? As a first step, they put in pedicle screws, distracted the interbody space. They used cutters that you can see on the top left to put it into the disc space to breed cartilage. Because I mean, at that point they understood the need for preparing the end plates for good fusion, right? You put in the interbody autologous bone graft, and actually importantly, people were encouraged to get up and out of bed, perform load-bearing exercises just a few days after surgery, right? Huge contrast to the previous larger surgeries that were done for interbody fusion. So these techniques didn't really go as smoothly as kind of make it out to seem, right? Because the hurdles that surgeons had to overcome early are actually the same hurdles that we have to overcome now. And when we're trying to make something more minimally invasive, right? With both Magdarell's and Liu's methods, right? The first hindrance was the fusion wasn't always robust, because you had difficulty placing the bone graft through a small exposure. You had difficulty preparing the disc through the exposure as well, right? And you obviously had primitive screws and interbodies that they were using at the time. And the second issue was that these externally placed implants didn't completely figure out a way to make them seated underneath the muscle when they started, right? And they could poke superficially and cause discomfort. But as minimally invasive fusion continued to evolve, some of the next stops were like transperitoneal, lumbar interbody fusion, thoracoscopic assistance for interbody placement, and percutaneous translaminar screws, right? Which I won't go into all of them, but these fell out of favor with more minimally invasive options for posterior interbody fusion. So in 2002, Kuh and Fessler reported the first MIS PLIF done with bilateral metric tubes here, shown on the left. You can see on the right, there's a way to do this unilaterally. These methods have clear advantages in the way that they minimize soft tissue dissection, devitalization, reduce the amount of bone that was removed, and reduce manipulation of the spinal cord too. So revolutionized interbody fusion when it was introduced in 2003, right? And like other MIS surgeries, the MIS TLIF has the benefit of a smaller incision size, less tissue dissection, less blood loss, decreased back pain, decreased postoperative pain, shorter hospital stay, so on, faster recovery. And in the right hands, it's a faster case as well, right? And like other MIS surgeries, the downside is that you have decreased visualization that can lead to inadequate decompression. You had the risk for a CSF leak due to the smaller exposure, but over time, people got more comfortable with it. The procedure gained widespread popularity, right? And the learning curve became more shallow. So this is a figure from one of the early papers that was published in 2004 by Reg Haid and Rusty Rhodes and I think Benny on the MIS TLIF, right? And the authors of the paper said that it was incredibly versatile, right? Because it could be performed using an endoscope, a microscope. It could be done with a mini open approach. It could be done open. And so they actually gave it the name, the VLIF, right? For the versatile lumbar interbody fusion. I mean, clearly that name didn't stick on, but whatever. The first steps in this TLIF are, very similar to the steps that we use today. You do a minimally invasive decompression first, and you put in the contralateral screws, you distract it along the rod, then you prepare the inner space. The graft, you put in the graft, and then you compress the rods down. But interbody fusion isn't only limited just to the phase, right? In 1982, Henry Bowman at Case Western described a way to treat high-grade spondies using 2 fibular grafts that were inserted through the S1 and L5 bodies, as you can see here. So this essentially was kind of like a standalone interbody technique, right? But there were complications from this procedure, right? There was fibular graft fracture, graft reabsorption, split progression, pseudoarthrosis. So this was initially introduced before the widespread use of pedicle screws, but now that pedicle screws have been introduced, right, you can supplement this with, obviously pedicle screws, pelvic fixation, transsacral screws, transvertebral interbody cage fusion, and intersacral rods, right? But reverse Bowman procedure, right, in which you place a graft through the L5 vertebral body, the L5 S1 disc space, and the S1 body from an anterior approach. And actually, Dr. Levy put out this paper that compared and validated, I think Ari was on that too, they compared and validated the reverse Bowman procedure and the modified Bowman procedure. It showed that the reverse Bowman procedure was a viable option for respondee, right? I really use this for the same indications, but this transaxial approach was developed in 2004 with a percutaneous presacral approach. They called it the axial lift. And in this approach, you make an incision more inferiorly in the medial gluteal regions, and then you pass the tube through the avascular adipose tissue and anterior to the sacrum and the coccyx, and then you place a graft from S1 to L5, right? So lastly, this isn't something that we do very much. I'm not going to spend a lot of time on it, but in 2009, Santoni who was a biomechanical engineer, he wasn't a physician. He suggested using a medial to lateral trajectory for screw placement. And the goal of this was to traverse more cortical surfaces, right? Call it the cortical screw. So that way you get more purchase in the bone. You can see this trajectory here on the left, right? And even with a smaller screw length, they saw that the pull-out force was 30% greater than with pedicle screws because pedicle screws are more in cancellous bone, right? And so one upside to this was you could do a percutaneous fusion using a fixation using a smaller incision, right down the midline. You can put in screws on both sides. There's Unilateral modified this to include like a midline lumbar decompression approach. Obviously I didn't want to spend much time talking about this. It's not commonly done, but it's something that people see when you're revising other people's instrumentation. You can do facet screws in a similar way with a single midline incision, putting bilateral screws through that. For surgical treatment of pars defects, right, is one thing you can do is fuse across the level of the defect, but this has one downside of taking away that motion segment, right? And so pars screws were devised in 1970 by Buck, and their way to prevent this need for fusion by fusing just across that defect, by just putting a screw through that defect. And they obviously minimize, so if you do this percutaneously, right, you minimize tissue dissection, preserve more normal anatomy. And there's another paper from Levy in 2013 with the use of metrics tubes to disconnect the fibrous tissue and then prepare the bony edges to actually then use a separate incision to put a lag screw in across the defect. A lot of times, the standard of care for these patients with vertebral body fractures and intractable pain is going to be a spine fusion, right? But one alternative that arose in Europe in 1984 was the percutaneous vertebroplasty. So Galabert first described this for a vertebral angioma. This is what he used it for. 94, Jensen applied this technique for the treatment of osteoporotic vertebral compression fractures, and that eventually led to its growing popularity here in the United States. In the mid-1990s, was modified to the kyphoplasty procedure in a way to restore sagittal alignment, minimize risk for cement extravasation, and cement toxicity. Obviously, you avoid other complications that you get with the percutaneous vertebroplasty, and this actually avoids a more invasive fusion surgery across the vertebral level. So osteobiologic treatment of compression fractures is like another novel idea that's emerged more with the kyphoplasty. You can see here people have tried to put in these spinology mesh cages into compression fractures and then fill the bag with bone graft. And the porous mesh of the bag actually allows bone to grow through it and heal the vertebral body from within. A different challenge, lumbar spine for MIS spine surgery, because you can't retract the spinal cord. And so this, a big component of MIS for the lumbar spine is actually retracting the thecal sac, right? And so, a big part of the room that you create within the lumbar spine is actually from retracting the thecal sac to get access to the disc space for either decompression or fusion. And so like most of the approaches to the thoracic disc space and the region ventral to the cord had to be done with large exposure with a laminectomy or, costal transversectomy, a transsternal or transthoracic approach. But this changed in 94 when thoracoscopic video assisted spine surgery was developed by Rosenthal and was used across Europe and the United States. So initially this procedure was reserved for the treatment of herniated thoracic disc, tumor biopsies and fractures affecting the vertebral body, but over time the indications expanded to address tumor, interbody fusion, infection, scoliosis. And when they analyzed the outcomes, they actually saw that this approach was much more favorable, had a much more favorable morbidity profile. And even today, like a large ventral thoracic lesion that needs to be removed, most people do it through a laminectomy and transpedicular, right? it's still I think an area that we can continue to improve on. But now looking at cervical surgery, right, cervical decompression fusion was first accomplished from posteriorly in 1925 by Ellsberg and later in 1934 by Mixer and Barr. And even ventral pathology like cervical discs were treated from posteriorly because they saw that there was advantage in preserving the disc space and preserving motion. So what they did was actually open the dura, they rotated the cord and then incised the anterior dura and then took out the disc, which obviously, I mean, had terrible results, right? Spinal pathology was later approached anteriorly with an intracervical discectomy with Robin Smith in 1955, and then was modified by Cloward in 1958. Due to the morbidity of opening the dura and rotating the cord, right, this approach served as a more safe option for decompression. So there are many similarities between Cloward's papers and today's method of the ACDF, preoperative needle localization, transverse incision along the skin folds, like identifying and separating the areolar tissue between the carotid and the trachea. He used METs as well, cauterizing the longest Hauser retractors. But unlike the ACDFs of today, he actually used the Hudson cranial drill to create a large circular hole at the level of the disc base. And then he usually didn't go through PLL unless it was already disrupted by the herniated disc. So like in thoracolumbar spine, right? Cervical spine surgery underwent many iterations to decrease the surgical footprint. And in 1951, Freicom was the first to describe a posterior cervical foraminotomy. And so he estimated that of the operable cervical discs, about 95% of them were located laterally, and the majority of the discs were soft and not calcified. So what he wanted to do was a keyhole posterior fascicectomy, the cervical spine to reach around the cord between nerve roots and then pull out the lateral disc. In 1968, Verbees devised an approach for anterior cervical foraminotomy that didn't require traversing the disc space. So this was actually derived from a spinal AVM that arose from the vertebral body. And the surgical approach involved exposing the vertebral artery between the transverse processes by removing the anterior rim of the transverse foramen. And when he did that, this exposure gave him great access to the lateral vertebral body, the foramen, and the anterior ramus brachial plexus. And he applied this technique to patients with lateral cervical disc and lateral osteophytes. And in the last 50 years, there have been many iterations to these procedures in MIS, cervical surgery by Hakuba, Joe, the use of the tube, and endoscopic procedures for central and foraminal decompression. So I want to go into that, but there's been a lot of advancement in cervical surgery. The cervical laminoplasty was first described in 1982 by Suji for the treatment of cervical myelopathy using a posterior approach in a way that didn't require fusion, right? And he actually first described this both in the cervical and the thoracic spine. And the benefit over the laminectomy of fusion was that it preserved motion and it decreased risk of postoperative spinal deformities compared to just laminectomy alone, including cervical kyphosis, right? And so now preserve bone posterior laminoplasties, right? The thought was that detachment of the posterior cervical musculature can still contribute in some degree to postoperative cervical kyphosis and neck pain, right? So, obviously names that you guys all know, Wang, Green, Levy, right? Found a way to, do this with an MIS approach to reduce muscle dissection while still preserving, lifting the lamina and still, keeping the same amount of cervical decompression, right? This was done by making stab incisions at C4 and C4, 5, C5, 6 bilaterally. It's a 22 millimeter tube to get to the lamina facet junction from 2 to 7. Drill troughs and then put in a 10 millimeter rib allograft through the open door side of the laminoplasty. Here you can see kind of the intraoperative views and the CT. So posterior cervical fusion has undergone many indications, right, from iterations from wiring to lateral mass plating to the most recent version, right, lateral mass screws. And so the same tubular approach for the laminoplasty was, why not do it with the lateral mass instrumentation as well, right? In the same year in 2003, the same guys out of Miami, found a way to place these lateral mass screws using the tubular dilator system, even in patients with set dislocations, as long as you could reduce that dislocation, right? This incision for this is at midline and at 3 segments below the level of interest to get the appropriate magnal trajectory. You can still get bony fusion in this technique by removing the facet synovium with the curette and packing the facet lateral masses with bone. And the obvious benefits to this are that you preserve the posterior tension band and that you have less dissection of the cervical musculature, which speeds operative time, decreases blood loss, and reduces postoperative pain. But patient selection is important, and you can't, achieve decompression using a laminectomy necessarily with this. Parallel to the development of minimally invasive decompression fusion techniques was the rise of endoscopic spine surgery. So endoscopic spine surgery arose from 2 procedures. One was percutaneous surgery with radiographic targeting, but no direct visualization. And the second was direct visualization without the ability to manipulate tissue through the same working cannula. But both of these eventually evolved and combined together to form endoscopic surgery. And the first reported surgical procedure using the endoscope was reported in 1868 by Bevan to investigate pathology of the esophagus. And the first endoscope with a working channel was actually the cystoscope, which had a channel to pass instruments through, also had an illumination and optical lens for reflection. This was described by Nietzsche in 1879. So neurosurgery, the first use of an endoscope was in 1910 by a urologist who used a rigid cystoscope to cauterize the choroid plexus in 2 infants with hydrocephalus. Now, if you look at the history of endoscopic spine surgery, one of the first percutaneous decompression procedures was done in 1964 by Lyman Smith, a spine surgeon in Chicago. He put this paper out on chemonucleolysis, chemonucleolysis, which was the enzymatic degradation of the nucleus pulposus of herniated disc with this enzyme chymopathin, which was made from the latex of the papaya plant. And so this could actually hydrolyze proteoglycans and lead to the depolymerization of the nucleus from within. And so it was sort of essentially a method of like indirect decompression. So this was one of the x-rays from the original paper. And so this procedure gained popularity in the 1980s, right? Because it didn't require an open or minimally invasive incision, but, it was eventually FDA approved, but the efficacy was, highly variable. And, you have, side effects to this, obviously, like hemiparesis, paraplegia, meningitis, hemorrhage, high ICPs from inadvertent injection of this enzyme into the fecal sac. Was 1955 by Hijikata and Tokyo. He was a Japanese spine surgeon, and unlike Smith, he used enzymes for the chemical degradation of the nucleus pulposus. He found a way to actually surgically remove it, the central and paracentral components using fluoroscopic guidance. The first step here was to do a discography and inject a blue dye to stain this portion of the disc that was herniated. And then he put in a 5mm tube down to the posterolateral annulus and then made a circular annulotomy and then take out the dyed disc with the pituitary. So he found that, pain, about 75% of patients did better over a 12-year period. Obviously, the famed, Parvis Camden, right, the Hammond Triangle, right, the Philadelphia spine surgeon, further developed and refined this procedure in the 1980s, and at the same time described this, triangle as a window for the approach for percutaneous dystectomies. So he did his first percutaneous dystectomies awake, just under local anesthesia, using fluoroscopic localization without endoscopy. And he said that if you insert a cannula into the dorsolateral disc at 10 o'clock or 2 o'clock, and starting about 9 to 10 centimeters to the midline and keep the cannula parallel to the end plate, you could pass through this triangle and avoid injury to the exiting nerve root. He's a 5mm wide cannula, and after making the annulotomy, removed the herniated portion of the disc with suction of pituitaries. In his first series, he found that symptoms improved in 72% of patients, and he had no serious complications, infection, discitis, nerve root vascular injury. See much of that. So this procedure eventually involved one that used biportal access. He had one for instruments and one with the 2.7mm glass arthroscope for viewing. That gave him more degrees of freedom because he could move independently. And so this delineation of the safe entry zone actually really drove the shift from percutaneous procedures to endoscopic procedures, right? This allowed surgeons to move from using small needle-like instruments to large instruments within this working corridor of the endoscope. Endoscope that, concerning targeting instruments, but the visualization part actually started much earlier. And so one of the earliest forms of spinal visualization was the myeloscopy, right, which was done in 1931 by Berman. And so, this, so Poole expanded on this in 1942 with intrathecal endoscopy using a modified otoscope. But both of these quickly obviously fell out of favor because of the morbidity of inserting this large bore scope through the dura into the thecal sac. And so even the authors noted that the size of the scope in comparison to the spinal canal was just, kind of unreasonable and made visualization difficult because they saw the size of the canal was about 3/8 inch in diameter, and the scope was, when the scope was bigger, they can actually visualize, anything once they put it in there. And so some surgeons adapted this concept of visualization to the disc space, and they called it nucleoscopy, but actual tissue manipulation wasn't combined with it for some time. There was still a lot of challenges to overcome before endoscopy could gain widespread acceptance, right? In 1937, actually, Husnick, who was an orthopedic surgeon, thought orthopedic arthroscopy was impossible, right? And actually, this is something that sort of has relevance to us as well. He thought, how could anyone put in, this object right into a knee and then look between articular surfaces, you can't separate them, right? And he thought it was impossible, right? This is a very important point, right? Like I said, like general surgery where you can just expand the abdomen and put in as many instruments as you want, in the spine you need to displace or remove something in order to visualize what you can see, what's in front of you, right? And here, so far, I mean, endoscopic were on the rise, right? It was still far from being a perfect procedure. And sort of, going back to that quote, it was hard to learn and apply for many surgeons, right? And there are a couple different reasons for this, but, I think maybe 3 reasons as to why this happened. This is just my idea. I think one was that the initial endoscopic cases were actually done dry, right? So you didn't have the use of constant irrigation to flood the field. And so this irrigation actually has many benefits, right? One is it clears away the blood and soft tissue, right? Improving visualization. So Greg mentioned during his grand rounds, right? Sort of works as a third hand to push away the dura and other structures to create working space, as you can sort of see here, right? Constant irrigation, you have hemostasis, and it reduces the rate of postoperative infection and hematoma formation. So that clearly helps, ease, make it easier to do these endoscopic procedures, right? Second was the development of new endoscopic approaches, which made previously unreachable pathology kind of more within reach, right? So for example, using the interlaminar approach for, L5S1, or, now taking, the endoscopic TLIF and using, endoscopy to do, fusions that were done previously open, or using the endoscope for ALL release, which I'll get into a little bit later. I mean, there's, so many iterations of this, like people are doing odontoidectomies endoscopically, treating basilar invagination, treating odontoid fractures endoscopically. So with the expansion of indications, right, that introduces, kind of more, more people into the field as well, right? And I think the third barrier was also the initial relationship with industry as well, right? Or, maybe the lack thereof, right? Endoscopy in the beginning was just a subset of MIS spine surgery, right? And the tools that were used in endoscopic spine surgery initially were taken from the general surgery lab, the laparoscope or the orthopedic joint surgery, right? And so this means you didn't really have dedicated instruments that could be used for the spine, right? And obviously the spine is different in both, right? Because unlike orthopedics where everything is bone, you have the bone of the spine, right? But then you have obviously all the soft tissue and the neural elements you have to protect, right? And like general surgery where everything is soft, you got to get through bone to, get to what you're decompressing, right? And so you need, actual specialized tools for endoscopic spine surgery, which makes using, other people's instruments much more difficult, right? But after you get through these growing pains of, of endoscopic spine surgery and that starts to catch on, you get industry on board, introduce high-speed drills, rongeurs, and other instruments that make spine surgery a lot easier. Right, the first use of endoscopy with combined visualization and tissue manipulation was in 1991. Right, momentum in spinal endoscopy, right, started to pick up when Oppenheim and spine surgeon in California used a laparoscope to perform a lumbar discectomy from an anterior approach. So he actually went through the peritoneum, gained access into the anterior disc space. And once at the disc space, he removed about 20 grams of disc until he could see the posterior aspect of the disc through the laparoscope port. So he actually saw SSCPs, which you can see here from his original paper, return back to normal. And so he didn't put anything back into the disc space after he removed it, but he saw this patient's symptoms resolved even at long-term follow-up, right? So this was kind of the true first endoscopic spine surgery in which both manipulation and visualization of the spine were done simultaneously. Report, Zuckerman performed an endoscopic ALIF in some patients using between L4 and S1 using titanium cages packed with autologous bone. So he did this with the same transperitoneal laparoscopic approach. In fact, this anterior approach was more favored, they thought, because it didn't disrupt the posterior tension band to maintain spinal stability, avoided excessive spinal cord and nerve root manipulation. But the downside to this was a high risk for retrograde ejaculation and potential injury to the great vessels, right? From here, endoscopic surgery, spine surgery, really took off, right? John Regan at Texas Back used a similar endoscopic technique for ALIFs and, 34 patients in the 1990s, used the laparoscopic transperitoneal approach for, L4-5, L5-S1 ALIF surgery. But one big caution he noticed was iliac venous injury, which occurred in 2 out of 34 patients. He also thought visualization was pretty difficult using the laparoscope. And so he converted, some of those patients intraoperatively to open. And so, after this laparoscopic ALIF, people returned to work in about 3 weeks, which is faster compared to the open ALIF. 92, Fessler, took and modified the endoscopic retroperitoneal approach that was used for urological procedures and introduced to the lumbar spine. And in 1997, he did lumbar fusion using this technique. And so these papers aren't from his original publication, but they're from one that validated this technique, right? So I don't want to spend all this time completely on the history of endoscopic surgery, because that could be a whole talk by itself. But there's one other point worth noting, right? Hammond's triangle was used as an approach for percutaneous dystectomies, right? That was the precursor to endoscopic spine surgery, and he used that through a a transforaminal approach, right? Just like endoscopic approaches, right? But when you're shifting from this transforaminal percutaneous discectomy to the endoscopic discectomy, it's not just a change in visualization, right? It also marked a change in how these discectomies were done, right? Because when you're doing these percutaneous procedures, you do indirect decompression, just use, forceps blindly, nucleotome chemical agents, and so on, right? But with the endoscope, you have the ability to do a precise discectomy under direct visualization, but more importantly, you're working in the epidural space. You're not going into the disc and kind of removing everything and just hoping everything, sort of, sits backwards. So, again, like endoscopic spine surgery has a lot of nuances that would take a lot of time to go into, like I'll save for another grand rounds talk. But I think one important take-home point of endoscopy is that the footprint is so small that the applications are like diverse and seemingly limitless, right? It's not just limited to discectomies. You guys all know about, and the Wang endoscopic TLIF, right, which can take this fusion and make it an awake procedure. But you also have applications of deformity, and with ALL releases, right? These are papers from, I think, Wang, Roberto, and Greg, which are all on PubMed. So I won't go into it here, but the possibilities are really endless. But advances in endoscopic spine surgery, they're intertwined with the development of technology, optics, and digital image processing, right? And one major development in endoscopic spine surgery that increased surgical appeal was developed by Hopkins, who's a professor of optical physics at the at somewhere in England. So he developed this new lens system for rigid endoscopes, and he engineered a coherent light conducting system, like a fiber bundle enclosed in a metal sheath that kind of enhanced the design of these flexible endoscope. And the reason optics is so important in endoscopic spine surgery is that it has to do with the kind of visualization that you achieve with the endoscope compared to the microscope, right? What I mean by that is it actually takes your eye and it moves it directly into the site of the pathology, right? So the examples I kind of gave you are extreme, like, on the extreme end of this, but it's like the difference between like looking at Mars through a telescope versus like actually putting a rover there and like, looking at it like in person, right? And then, we're looking at, something using real, like, real-time satellite imagery versus like sending a drone, right? So that means like any advances you have in optics and digital image processing can be coupled with, the endoscope, and they have a significant impact on visualization, right? It's one of the most important things in endoscopy. Because I think we're running a little short on time, right? MIS deformity have been approached, explored in the last 2 decades, right? It's still a field of constant innovation and, potential that's still untapped. And some of the current mainstays in MIS deformity correction include like percutaneous screw placement, MIS TLIFs that we already talked about, but lateral and anterior the psoas approaches for interbody fusion, lateral and endoscopic approaches of ALL release, percutaneous iliac screw placement, mini open PSOs, and so as all these come together, you really encompass the spectrum correction that's needed for deformity, right? The lateral interbody fusion was first described in 1997. For approaches to the L2 to 5 disc space, and Clement expanded on this more. Here's some of the images from the original paper. You don't need an access surgeon, right? It can be a quick procedure. You can access multiple levels through the same incision. Decreases operative time, highly effective in treating coronal deformities. And compared to ALIFs, you have a decreased rate of vascular sympathetic chain injury, but higher rate of lumbar plexus issues if you're not careful. And so the issue with the lateral is it's hard to get down to L4 and 5 due to the iliac crest, right? But the ATP approach gives you access to the retroperineal corridor, and you can pretty much access the entire lumbar spine, with just 1 or 2 incisions. At least, from that paper, but the benefit of ALL releases and deformities that allows for expansion along the anterior column and placement of these hyperlordotic cages, useful in restoring sagittal alignment. You can get to 15 to 30 degrees of lordose at every level. And so, it can be done lateral, anterior to psoas approaches endoscopically. And looking at one other thing is like clinical subtraction osteotomy, right? It's a mainstay of deformity correction because the amount of lordosis that can introduce in treating severely kyphotic patients. So there's a paper from Wang in 2014 on the mini open PSO. I tried to make this talk more about the history and advantages of surgery than the actual steps of the technique. So again, the paper is online, so I won't get into the steps of it because there are people more senior than me that know them a lot better. But the clear advantages of this are, unlike the traditional open PSO, you only require the explosion that kind of like a 1-level fusion would, right? And you put in percutaneous screws at the level above and below the PSO, and you use 4 rods subfascially, and you get control of the spine in 3 dimensions, right? patient iliac screws were initially invented in 1982 with the Galveston technique. And iliac screws are crucial for long segment constructs because you bolster the bottom end of the instrumentation, right? And you have a significant advantage in biomechanical strength, right? And with the widespread use of percutaneous screws for pedicle screw placement, right, it only makes sense that iliac screws, also have a percutaneous technique, right? So again, this is like another paper from Miami, with laying on iliac screw placement. The key steps are obviously finding the obturator outlet view, avoiding a sciatic notch. But even with all these techniques in MIS deformity correction, we haven't really reached a point yet where MIS is an option for every single deformity, right? Like people with high-grade spondies, large comb angles, still difficult to correct with a purely MIS approach, right? So the key is going to be preoperative planning to figure out who benefits from MIS deformity correction and who benefits from open correction, right? This is kind of the driving force behind the the MISDEF series, right, which looked at an algorithm to figure out which patients are going to do better with MIS versus open, right? And this algorithm is always evolving, right? So you have and even with these advanced MIS techniques, right, you have to constantly keep this updated, to see which patients would benefit from what, right? And there have been ways to use MIS technique for intradural pathology too, tumors on time, but part of MIS techniques is going to be ability to get bony fusion, right? Because for example, posterior percutaneous instrumentation for trauma, right? You aren't able to put down bone graft in the gutters, right? So doing an MIS TLIF or endoscopic TLIF, right, doesn't necessarily means it's going to be tougher to get the same amount of fusion with less exposure, right? So that's why the use of allograft, bone substitutes, and biologics are critical for the advancement of MIS spine surgery, right? The morbidity and pain of using like the patient's own bone, like iliac crest, drove the need for allograft production, right? And this started in 1958 with like Flowered's use of fresh frozen cadaver ilium dowels for the use of anterior cervical fusion that you can see here. They put on postoperative X-rays, right? One obvious advance to this is BMP, right? The development of BMP was one of the most published advances in the history of spine, right? In 1965, Urus used demineralized bone matrix in the rack exoskeleton, found that it caused differentiation of cartilage and bone, cartilage to bone in 1965. And after 19 years of laboratory work, he isolated the substance, named it BMP. 14 other subtypes have been isolated, the ones with Medtronic, Stryker. So, there's, more that I can go into about, like kind of radiography and how like image acquisition is very important. I'm going to, conclusion-wise, take-home points. I have a huge evolution in terms of how MIS spine surgery has come about in recent history. You have so many ways you can go about developing just a single sort of branch of these, and a greater proportion of the field will inevitably be treated with these MIS techniques. And like I said before, there's really no limitation on the people out there that can do MIS surgery, right? Anyone can say they can do MIS. So really, the real success in this field is going to be driven by results. All right.